Conference or the first annual combined OB and Anesthesia Symposium on Preeclampsia. The Department of OB-GYN is proud to participate in combined research efforts, forwarding knowledge in this field. We welcome both teams to this interesting symposium, and hopefully that will lead to perhaps NIH grants and further collaboration. Everything we have in OB, in terms of specimen and everything else, we will be more than happy to share with you. Thank you so much and welcome.
Good morning, everyone. We have a nice crowd here for this early, right, on Monday after Easter. This is officially the opening of the Preeclampsia Center, and it's a center that Ming Zhang had in mind for at least a year, maybe more, based on some of his research and in talking with the clinicians. And it's based on science and in translational science that goes into clinical care. And it's a not-for-profit, and hopefully the center will serve people of the community and get referrals from all over Brooklyn. So it'll be a nice clinical service for the people of Brooklyn. This morning we have a group of very good speakers that are going to tell us about preeclampsia. One's going to give the anesthetic aspects of preeclampsia. One is going to talk about the obstetrical management of preeclampsia, and then Dr. Zhang is going to talk about the scientific basis of preeclampsia. So it looks like it's all interrelated, and we should learn a lot this morning, those of us who are not directly related with OB or OB anesthesia. So without further ado, Dr. Toledano is our Director of OB Anesthesia at Lutheran Medical Center, where they have lots of experience. And she's invited worldwide to speak about anesthetic management of preeclampsia.
All right, today we're going to talk about new frontiers in the diagnosis and management of preeclampsia. I'm Rulak Toledano. I'm affiliated with SUNY Downstate and NYU Lutheran. And for all my obstetric colleagues, please don't hesitate to fix or correct anything I might say. As we know, things are changing with the diagnosis of preeclampsia almost on a daily basis. So let me know where I might be incorrect. I have no disclosures. So we're going to open with some general information about hypertensive disorders of pregnancy, and then move to an area that I think is a really important place where we might be able to impact the morbidity and mortality of preeclampsia, and that's specifically with the period of expectant management. That's the period when we try to keep the mother pregnant and watch her carefully and ensure that she is still healthy, but at the same time buy a few extra days or weeks in the best case scenario for the child to mature. So we're going to focus a bit on expectant management. And then we're going to move to cesarean anesthesia and talk about what's the optimal option or technique for cesarean delivery in a patient with preeclampsia. It's always of much debate. We're going to look at whether Neuraxial is appropriate. That's epidurals, spinals, combined spinal epidurals. And we're going to look at whether you need hemodynamic monitors like A-lines, etc. And then we're going to close with a look at eclampsia management. We're going to start with the case scenario of a 30-year-old P0 at 37 weeks. She's had elevated pressures for 24 hours. She had labetalol and hydralazine. She presented with a headache and right upper quadrant pain. And she has a category 2 tracing. She's otherwise healthy, no pre-existing hypertension. On exam, she has a Mallampati 3 airway. Is there anybody who doesn't know what that is? Just raise your hand. So 3 is almost the worst. This is a 3 out of 4. So it's a pretty bad airway that probably doesn't look favorable for intubation. She weighs about 100 kilos. Her blood pressure is elevated at 164 over 112. Her hemoglobin is 10 and her platelets are 78,000. And she has slightly elevated LFTs and, say, a protein creatinine ratio of 0.4. I know that we use that often to diagnose preeclampsia these days. So the plan for her is urgent C-section for a category 2 tracing and severe preeclampsia. Just note that when you see PET, that's how I've abbreviated preeclampsia throughout. This is an easy case scenario. This is a case that we know we're going to C-section. It's urgent, not emergent. We have time to place a spinal, even an epidural if we think it's necessary. But what I really want to think about is, what if this case scenario were of a woman who was 32 weeks, not 37 weeks? And what if her blood pressure were controllable with the hydralazine and her headache was abating? What would we do in that scenario? So this is just a way to open up the discussion about what options of care we have, delivery versus expectant management. Again, at 37 weeks, we're going to go ahead and deliver, ideally under spinal. All right, so moving on to the general information about hypertensive disorders in pregnancy. We're going to look first at the definitions, and then we're going to focus on maternal and fetal morbidity and mortality, and the risk factors that make this preeclampsia in particular a disease that's on the rise. And then again, we're going to focus on delivery versus expectant management. Okay. Hypertensive disorders of pregnancy, there are 4 of them, and I know my obstetric colleagues will be sleeping at this point, but just a reminder, chronic hypertension is defined as blood pressure. We're looking at blood pressure over 140/90. It's pre-pregnancy condition, before 20 weeks, and it's not associated with proteinuria or end organ dysfunction. Gestational hypertension develops before 20 weeks, but it's not, after 20 weeks, after 20 weeks gestation, and is not associated with proteinuria or end organ dysfunction. Now, preeclampsia develops after 20 weeks up until the postpartum period, but it is associated with proteinuria or end organ dysfunction, and we'll look specifically at what comprises end organ dysfunction. And chronic hypertension with superimposed preeclampsia develops, obviously it's a pre-pregnancy condition that worsens over the course of pregnancy, and at some stage they develop proteinuria and or end organ dysfunction. Of note, patients with chronic hypertension and gestational hypertension both run a 25% risk of developing preeclampsia during the course of their pregnancy. So as many of you know, in 2013, ACOG, the American College of Obstetricians and Gynecologists, changed the criteria for diagnosing preeclampsia. So you no longer hear mild and severe preeclampsia. We hear preeclampsia with severe features and without severe features. Also, if you participate in huddles on your L&D floor, you'll notice that people no longer quantify protein, and you don't even have to have proteinuria to define preeclampsia. So things have changed pretty dramatically. What we need now is elevated blood pressure of either over 140/90 or over 160/110, and proteinuria, or one of these new onset signs or symptoms of thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or visual changes, or a headache, for example. So things have changed a lot. They found out that proteinuria did not really correspond. The degree of proteinuria didn't correspond with the severity of the disease, and it was a timely 24-hour urine collection. So that's no longer required in the diagnosis of preeclampsia. This new definition also urges us to constantly reassess whether severe features are present. Because if we say, oh, we have a preeclamptic without severe features, it prompts us to constantly reassess, well, is she developing severe features? Because we don't want to miss the onset of severe features. Severe features in a patient with in a preeclampsia with severe features is 160/110 blood pressure with similar presentations of thrombocytopenia, impaired liver function, which could be 2 times the normal AST/ALT, or severe persistent right upper quadrant pain or epigastric pain, progressive renal insufficiency, as defined as a high or elevated creatinine of 1.1. Notice that 1 is normal in a non-pregnant patient, but not in a pregnant patient. Or pulmonary edema, or new onset cerebral or visual disturbances like a headache or blurry vision. Just a note, the HELLP syndrome is considered on the spectrum of preeclampsia, and it's much feared. It's hemolysis, elevation of liver enzymes, and low platelets in the pregnant patient. And again, it's considered on the spectrum of preeclampsia, but sometimes it develops without hypertension and without proteinuria. In one study, it affected 20% of the patients with severe preeclampsia, and it's associated with a high maternal morbidity, a high risk of abruption, DIC, renal failure, hepatic hematoma, recurrent preeclampsia in the future pregnancies, etc. The mortality is 1% for the mother and up to 34% if the fetus is delivered before 34 weeks. And of note, the symptoms may worsen after delivery. And then eclampsia is the last thing on the spectrum of preeclampsia that we're going to look at. This is new onset grand mal seizures in the patient with preeclampsia. Most patients, if they have prodromal symptoms, present with visual disturbances and headaches, but 20% don't have any prodromal neurologic symptoms. They may even present with an eclamptic seizure as their first presenting symptom. The morbidity is associated with renal failure, pulmonary edema, aspiration pneumonia, stroke, and cardiopulmonary arrest. It occurs in about 1 in 1,000 deliveries in the United States. In the developing world, the mortality is as high as 15%. So why are we looking at preeclampsia and more broadly at hypertensive disorders of pregnancy? Well, one problem is that in the United States, maternal mortality is on the rise. This is unlike neighboring countries and unlike many countries that we compare ourselves to sort of historically. And hypertensive disorders of pregnancy and relatedly stroke or cerebrovascular accidents account for a large proportion of those deaths. In a California study, 17% of maternal mortality was attributed to hypertensive disorders of pregnancy. We're also looking at this today because preeclampsia is on the rise. And the most common cause of death in preeclampsia is stroke, and particularly hemorrhagic stroke, secondarily thrombotic stroke. But hemorrhagic stroke accounts for about 90% of the strokes. With regard to the neonates, hypertensive disorders of pregnancy are a leading contributor to premature births and all the risk factors associated with that. Seizures, neonatal encephalopathy, prolonged ICU or NICU admission, and a twofold risk of death. Why is preeclampsia on the rise? You'll see, in part, that a lot of the risk factors that predispose us to preeclampsia are on the rise. Pregnancy in women of age over 40, pre-existing hypertension, non-smoking status. I like to think that that's on the rise, that fewer people are smoking. Being a non-smoker predisposes you or is a risk factor for preeclampsia. Other things that predispose us are comorbidities like diabetes, renal disease, lupus, history of preeclampsia. African Americans are predisposed. Multiple gestation, like a twin gestation, nulliparity, that's being the woman who's never had a baby before, and obesity, which of course is on the rise. So what are our options when these people present? With patients with, we have to decide, the obstetricians more than us, are we going to deliver or are we going to embark on this period of expectant management where we might be able to buy a week or two at the most to let the fetus develop in utero a little bit more without compromising the mother. So patients who have severe or preeclampsia with severe features can be delivered at 34 weeks and less than 34 weeks if the mother is unstable or any fetal instability develops, like a category 3 tracing. If we can, before 34 weeks, we'll give steroids and wait 48 hours. But you have to watch the mom continually for a change in her status. And if she develops uncontrolled blood pressure or pulmonary edema, or a non-reassuring fetal heart, or a concern for an abruption, obviously we'll have to delay, or we will no longer be able to wait 48 hours for the steroids to take effect. With preeclampsia without severe features, we deliver at 37 weeks, or that's considered fine. and earlier if the mother or the fetus is unstable. And chronic hypertension, we hope to get to 38 weeks and then deliver. For a certain patient population that's able to be controlled with regard to their signs and symptoms, and their blood pressure is controllable on antihypertensives, and they're maybe between 24 and 34 weeks, if we can, we'd like to embark on expectant management and watch these patients, preferably in the hospital on the labor and delivery floor. And expectant management, again, just is a delicate balance between trying to buy some time for the baby in utero and without jeopardizing the mother's health. So we constantly, there are 4 tenets of expectant management, although definitions vary. Maternal and fetal surveillance, blood pressure control, and the purpose of that is to prevent stroke, seizure prophylaxis, and preparation for delivery. Here's a cartoon of the 4 tenets of expectant management. As you see, the median range is 7 to 14 days, although the patients who present earlier with preeclampsia tend to have a more severe course and often don't stay many days in the expectant management phase. What can the anesthesiologist do during this? This is really a collaborative effort to take care of these mothers and these babies. So right now we're going to focus on what the anesthesiologist can do during the expectant management care phase of care. We want an early anesthesia consultation, and also other groups need to be consulted, like NICU, maternal fetal medicine, etc. We need to participate in the constant reassessment of disease progression. If you're in a huddle and you hear them talking about, oh, her headache worsened last night, but it's better on Tylenol, but it still seems pretty bad, it's really important that we all say, this is not sounding good, and we try to, as a group, not overlook progression of disease. I mean, it happened to us last week. There was a debate between the day team and the night team about whether to deliver a severe preeclamptic, and we were, discussing whether her headache and her O2 sat of 92 was real or not, and should we deliver or not. If we can, we need to participate in those decisions. We need to participate as anesthesiologists. We need to help the obstetricians maintain aggressive blood pressure control. If we can, we'll place an early labor epidural. We need to maintain fluid restriction intraoperatively and ensure that there's restriction throughout the stay on labor and delivery, and ensure that there's seizure prophylaxis with magnesium for the severe preeclamptics. And if a patient develops eclampsia, we'll help stabilize. So I do oral examinations. I prepare anesthesiologists for oral exams, and I always ask them a question about preeclampsia, and I ask, what do you want to know about this patient? When we do the anesthesia consultation, this is what I want to hear. You want to ask the patient, you want to find out about the severity of the disease. Does she have severe features? Does she have pre-existing hypertension? Are we concerned about HELLP? Has she received medications like hydralazine and labetalol that might affect the medications we give? Is she on magnesium? If so, we're going to make sure that we're running it throughout the course of her stay and intraoperatively. We want to look at her airway because these patients are prone to more edema and more friability, more bleeding than the normal pregnant patient. And that airway may worsen over the course of the hospital stay. We need to focus on the hemodynamic status. We assume they have a contracted plasma volume, although studies vary. Preeclamptics tend to be very vasoconstricted. They may have an element of cardiac dysfunction and myocardial damage, and pulmonary edema is specifically concerning. Just to give you an idea of airway and how it might worsen over the course of labor, this is a patient who doesn't even have preeclampsia. The beginning of her labor and at the end of her labor. This is a class 4 airway. I told you there was a 1, 2, 3, 4. That happens and even is magnified in the preeclamptic. We also need to focus in our consultation on the coagulation status, because ultimately we're trying to decide, can we place a neuraxial anesthetic, either a labor epidural or a spinal? And there are certain coagulation parameters that make that prohibitive. So preeclamptics are prone to some thrombocytopenia, potentially, and platelet dysfunction. So we need a platelet count upon an admission, and sometimes the obstetric group will forget that we need one every 4 or 6 hours, but at least 4 to 6 hours before we place our technique, because the trends are really important and they could drop quickly and precipitously, and we need to see. One thing is having a patient who had 85,000 platelets in the morning and 80 before we put the Neuraxial technique. It's another thing if they had 80, 85, 80, and then 40. That's not so good. Now, notice other coagulation studies are indicated if the platelets are less than 75,000. It pains me how much we waste laboratory resources. ACOG says 100,000, but it's unlikely that you're going to have abnormal coagulation if the platelets are over 75,000. So the anesthetic literature says you really don't need coagulation profile until platelets are below 75,000. Obviously, unless there's something else, like overt liver failure, DIC, something else. We also need to look at other hemostatic derangements, like most likely accentuated hypercoagulability, whether there's an abruption, because abruption's related to DIC, whether there's overt liver failure, whether there's HELLP, or DIC from hemorrhage, for example. So we'll do coagulation testing, preferably on an individual case basis. And part of our analysis is also to assess these patients clinically, to ask them clinically if they are bleeding in the nose and the mouth. Now, there's no cutoff at which we can do a Neuraxial technique. In a patient who has ITP, we could do a spinal at 50,000 because they're superfunctioning platelets. It's different with preeclampsia because of the possibility of dramatic drops and the possibility of dysfunction of these platelets. So we really need to look at them at the platelet trend and number. What else can anesthesiologists do? We can help you all control the blood pressure. ACOG says to initiate blood pressure management at 160 over 110. Other groups say start lower. We want to initiate management within 1 hour to prevent stroke. So if the person's sitting in the triage area, maybe you could say, "Ooh, I think that patient needs to be looked at." And if she doesn't have IV access, you can kind of speed along an oral medication like nifedipine. Our goals in blood pressure management are to prevent progression to severe hypertension and to reduce the risk of hemorrhagic stroke. In a study of 28 patients, everyone who had a stroke had a blood pressure over 160, except one who had a systolic blood pressure over 155. So really, your systolic pressure at 155 to 160 needs to be managed. I think all but 3 died. I'm not sure of the number offhand. Also, our goal is to maintain uteroplacental perfusion. We don't want to drop it too dramatically. We want to keep it around 140 to 150 over 80 to 100. And again, those goals vary according to different societies. What are our medications? Labetalol and hydralazine are first line. If the patient doesn't have an IV, oral nifedipine is more effective in some studies than IV labetalol. It only takes 40 minutes to reach your target and fewer doses. So remember, that's an option. IV esmolol and nicardipine are good options. And other things like propofol, potent vasodilators like nitroglycerin, nitroprusside can be considered. So ACOG tells us again to treat severe preeclampsia with severe features at 160 over 110. As you see, there are other organizations that have lower cutoffs, lower thresholds at which to treat. And again, we want to treat within 1 hour. Okay? There's an extraordinary initiative by the California Maternal Quality Care Collaborative that looks at different disease processes in pregnant women like hemorrhage and preeclampsia. And they have a bundle of a toolkit and very important resources that can help us determine how to treat preeclamptics and women who are hemorrhaging, etc. And they say that the anesthesiologist should be seen as a resource for the blood pressure management. And here I'll show you some descriptions of where we can play a role. If a patient comes in with severe hypertension, it specifically says seek consultation if her blood pressure is refractory, is not improving and reaching your goal. Seek consultation. And who are the consultants? Maternal fetal medicine, critical care, anesthesia, and internal medicine. So that's our role. We are there to help blood pressure control. This is from the California Collaborative, and it specifically lists what we can do. It's a toolkit to list what we can do to address the blood pressure problems. And look, it says esmolol by anesthesia only, and propofol. These are small doses, but we're there to help control the blood pressure. Again, we want another tenet of management is to ensure that there's seizure prophylaxis. Prophylaxis with magnesium sulfate has been proven time and again to reduce the incidence of seizures dramatically. It can also reduce maternal death and the development of abruption. The number needed to treat is very small overall, and it's a cheap, easy to deliver medication. A new recommendation by ACOG is that we continue it in the operating room. This is not elective any longer. It may, though, make our, if we're under general anesthesia, it may potentiate our paralytics, and it may also contribute to uterine atony. A reminder of how to load it, 4 to 6 grams, and look for side effects. This is for severe preeclampsia with severe features. And you can have minor or major side effects, and we need to keep an eye out for them and measure urine output, respiratory rate, and reflexes. If we suspect toxicity, we stop our magnesium and give calcium gluconate. If you give calcium chloride, it's like 3 or 4 times more potent. This is a reminder for those who are anesthesiologists. You always get tested. I assume the obstetricians do too, of the continuum of problems that you might have with magnesium as you get a higher level. Fluid management is another essential tenet of expected management, and we know that women with preeclampsia are prone to pulmonary edema. About 3% are affected, 3% with severe features are affected. The etiology is multifactorial, and in part it's iatrogenic. We give them fluids when we don't need to. So a restrictive fluid policy is recommended. This is a question all the people whom I give oral exams to get wrong. Oh yeah, we need to give a bolus. We need to give a bolus. I almost, without a doubt, they'll say we need to give a bolus before the epidural or spinal. Well, we don't. We want to avoid giving fluids. We want to minimize even the oral and IV intake. The IV intake should be 80 to 100 mLs per hour, and that includes your magnesium and your oxytocin. So, one last thing that we can do as anesthesiologists is do an early labor epidural. If the patient is here to stay and she's likely going to deliver in 4 days or whenever things take a turn for the worse, placing an epidural helps during this expected management phase. And in fact, the ASA, the American Society of Anesthesiologists, has said that placement may precede onset of labor or even the patient's request. So you see a severe preeclamptic, place the epidural before her platelets fall to 40,000. You may check, you probably need to check the platelets for a severe preeclamptic and or coags if the platelets are less than 75,000 or you suspect DIC. Don't give a fluid bolus. What are the benefits of an early labor epidural? It'll mitigate the sympathetic response to pain, so the hypertension will be mitigated. It'll decrease the mother's oxygen consumption, may improve placental blood flow. There's some studies putting epidurals in preeclamptic patients to see if their placenta has improved flow. And you can always use that epidural to convert it to cesarean anesthesia when the person, if there's an emergency C-section, you just dose it adequately for surgical anesthesia. Because the timing of because removal of an epidural may be just as hazardous as placement of an epidural with regard to a spinal epidural hematoma, which is our big concern. Check the platelets before you remove it. Now, when the decision is made to deliver these patients after, say, a week or 3 days or 2 days on expectant management, this occurs when the patient develops a headache, a persistent headache, visual changes, persistent epigastric pain, pulmonary edema, low O2 sats below 95,000, etc., or blood pressure that's refractory to treatment. At that stage, our expectant management comes to an end and we move to delivery. So what do? The optimal anesthetic for preeclamptic, including preeclamptics with severe features, is a spinal. Again, 100% of the people get this wrong on my oral exams. It is preferred over general anesthesia. You avoid the hypertensive response to induction and intubation, because intubation under GA, you may have a surge of blood pressure. You avoid instrumentation of an airway that's potentially really difficult. You don't have to give neuromuscular blocking drugs or paralytics. Of course, before you put a neuraxial technique like a spinal or an epidural, check the coagulation situation, like the platelets. The contraindications are coagulopathy, a persistent neurologic deficit after an eclamptic seizure, for example, and patient refusal. We prefer spinals over de novo epidurals. In other words, if the patient has an epidural in place for her labor, we can use that epidural. But if we're going back urgently and she does not have an epidural, let's place a spinal. It's a denser block, it's faster onset, it's a smaller needle, and it's safe. In 1950, we knew it was safe. Clinical trials proved that it was safe. In 1990s, those trials reiterated the safety. And more recently, we've discovered that they are well tolerated. Spinals are exquisitely well tolerated by preeclamptic patients. They have less hypotension, and they have fewer vasopressor requirements. That means they need less phenylephrine and less ephedrine than healthy counterparts. And we'll look at a few studies quickly. If you're going to do a neuraxial technique, either a combined spinal, an epidural, or a spinal, preferably a spinal, don't give the fluid. Once again, there's been no proven benefit to fluid to prevent spinal hypotension, and we know that there's a risk of pulmonary edema with liberal fluids. When we do give crystalloids, it lasts about 2 minutes. There's a very brief effect on the central filling pressures. Give a small dose of vasopressors. Don't give 50 or 100 of phenylephrine. Start with 25 or 50. They may have an exaggerated response. If you're concerned that this is going to be prolonged surgery, or you're going to get into hysterectomy or bleeding, you might consider a technique like a combined spinal epidural or a standalone epidural, just so you have a long time intraoperatively so that you can prolong your surgical anesthesia. Otherwise, spinal is considered the gold standard. There were 3 studies in the early 2000s that confirmed that spinals are well tolerated in preeclamptic patients. The first one they thought might have been marred by the fact that the preeclamptic patients had smaller babies, and so they thought, well, maybe there's less of an effect on aortic cable compression. So the same authors in number 2 repeated a study and matched the preeclamptics and the normotensive patients. They matched them for gestational age and fetal weights, and they found that the preeclamptics tolerated the spinal better than the non-preeclamptics. If you have to do a general anesthetic, which we would like to avoid, why do we want to avoid it? There's failed intubation is higher in this group because they have worse edema, worse bleeding. Laryngoscopy, putting the tube in, may trigger a hypertensive crisis. And because if the patient's under GA, we won't see whether they're having a stroke. We can't assess them for stroke. So it'll delay recognition of maternal stroke. Those are 3 reasons we want to avoid it. But if we have to use general, when Neuraxial is contraindicated, or if there's an emergency, make sure you have colleagues nearby, airway adjuvants. Use a typical rapid sequence induction with lidocaine propofol and succinylcholine. And be very careful to blunt the hypertensive response to putting the tube in. You want to keep the blood pressure below 160 over 110. And there's a list of medications that you might consider: esmolol, labetalol, nitroglycerin, nitroprusside, nicardipine, remifentanil. Do we need hemodynamic monitors? The ASA, the American Society of Anesthesia, says it's insufficient evidence to determine whether monitors will improve our outcomes. You may place a radial arterial line if you need to give continuous blood pressuring monitoring, or you want to see how the patient responds to our treatment. Central venous catheters are not recommended. They're recommended only if you have no IV access and you're going to administer central vasoactive drugs, which can probably be administered peripherally. A new emerging technique is transthoracic echo, which will tell us about the volume status and the cardiac function, but you need to be trained. There may be a role for some non-invasive monitors, like looking at the radial arterial waveform to estimate stroke volume and cardiac output. So a lot of studies are underway. If the patient develops eclampsia, what can we do? Give supplemental oxygen, support the airway. You may need to assist ventilate, but it's likely you won't need to intubate. The apnea lasts about a minute. You'll load with magnesium if the patient doesn't already have it. If the seizure hasn't terminated, give midazolam or propofol. The key is terminating the seizure and controlling the blood pressure. Thereafter, we want to monitor for magnesium toxicity and for neurologic recovery, and deliver after the patient is stable. When the patient has her seizure, don't run to the operating room. Let's deliver after the patient is stable. So, pearls. We want an early anesthesia consultation. We want to constantly reassess for disease progression and need to deliver. We want to be very aggressive with our blood pressure monitoring, and we want to ensure that the systolic is below 160, and systolic in particular is the important number here. We want to place an early epidural labor analgesic, because that will help the patient, blunt her hypertensive responses, etc. We want to help restrict fluid, ensure that magnesium is continued throughout the operating room and throughout the hospital stay. If we have to have an emergency or an urgent C-section, we can place a spinal. If you have to do GA, make sure that you blunt the hemodynamic response to intubation. Eclamptics don't necessarily need to be intubated. Stabilize the eclamptic before delivery. And if you come into uterine atony, best to avoid methergin. Again, my students all get that wrong. Methergin, just say it's not the option. You don't want to use it. And because of the hypertensive response. And communicate, because we can all together make a difference in the management of these patients. And that is it. Anything come to mind? Any changes, the management that you're surprised? Oh, that's a good question. So colloids, he's asking if there's a benefit of colloid over crystalloid for the fluid. Studies have not shown that colloid, like the thicker head-of-starch type things, fluids are any better or preferable to crystalloids in preeclamptics. The idea is that a colloid might stay intravascular for longer. The studies have not borne that out. Yep.
Can you clarify the rationale for doing fluid restriction? Because we always thought hypertensive, most often her body is contracted, and when you give her whether a general anesthetic or a Neuraxial anesthetic, oftentimes you can mask the hypovolemia. So we always thought preload patients with it before we.
Right. Well, that's the evidence, even for healthy patients, the evidence does not support preload for healthy patients, much less for preeclamptics. I don't think that the evidence is out there as to how they tolerate. The preeclamptics are the patients who have like railroad tracks throughout their C-section after their spinal. I don't know that they know exactly why, besides the fact that they're maximally vasoconstricted. But I'm going to leave it to my obstetric colleagues to talk about the detrimental effects of fluid in these patients. The outcomes are far worse when you develop pulmonary edema. A lot of them have cardiac dysfunction, so then it's just going to lead to further compromise. But I'm sure one of the speeches from the obstetricians will discuss that. Pulmonary edema is definitely to be avoided, and fluid restriction is encouraged, and preload isn't even helpful in a non-preeclamptic. Maybe a co-load for spinal in a non-preeclamptic. Anything else? Yeah?
You said methogen is contraindicated. Is there a role for induction of contractions with medication, or is the C-section always kind of the answer?
Oh, no. Ultimately, optimally, you'll have a vaginal delivery, and you can induce in these patients. The goal is a vaginal delivery. I guess you would induce with oxytocin. I'm just saying, in a postpartum situation, if you do, unfortunately, a lot of the deliveries end up being cesarean delivery. You know, if there's a failed vaginal delivery, or if there's some urgency, you'll go to C-section. If you come upon uterine atony, the methergin is the one that might cause blood pressure, is contraindicated in hypertensives. So, I mean, sure, you could maybe give it some, if the patient's 60/30 bleeding, you could consider it, but in general, methergin is contraindicated in hypertension. At least that's what I want to hear on my oral board exams. You can give the other medications if there's no contraindication, the Hemabate, the Cytotec, the oxytocin for uterine atony. Any other questions?
You mentioned a transthoracic echo being helpful. Could you expand on that? How many delivery rooms might have that capability?
Yeah. So he's asking about transthoracic echo. It's growing in such numbers. So easy. Sometimes, have you noticed, you can be looking at the baby, and just roll it up, and you can see the volume status. You can check the heart volume and function. You can see if it's a beating heart, if there's volume or not. I think that it's gaining a lot of popularity. You do have to be trained, and you have to maintain your training. And I don't know, Dr. Willody, would you know what number of people use transthoracic? I know that like Mayo Institute does.
I think it varies from site to site, and we are making the effort here to train the residents in transthoracic, and I hope to make it a bigger part of our evaluations here.
Do you have a transthoracic echo on labor and delivery?
It's available.
It's available.
Installed in OB, we have to bring it back upstairs.
Yeah, well, so the poor man's is just to take the one that they're using to gauge the baby and just kind of roll it up to the heart. I've done that in hemorrhage situations, but definitely a skill I want to learn. Anything else?
What about the effects of raised intracranial pressure? Do you have to look for that? Do you have to do anything?
So you would consider that in the setting of an eclamptic seizure and a person who's not recovering adequately. At that stage, you'd have to think, is this patient having some element of intracranial pressure? And that would certainly be something you'd have to consider prior to neuraxial placement. But in the general sort of run-of-the-mill headache that these patients present with, we don't... It's such a part of the constellation of symptomatology associated with preeclampsia that we really don't rule out elevated intracranial pressure. Dr. Willody, does it ever come up to you, intracranial pressure, when the patient presents with regular headache without the eclamptic seizure?
I don't ever put that very high on my list.
Yeah, but if they had an eclamptic seizure and they weren't recovering, sure, you would think about it at that stage. Thank you so much.
Thank you. We have a guest with us from the Caribbean Women's Health Association, Deborah Lassane, and you brought a guest with you, a doula? Yeah. Yes, hi, welcome. What's your name? Okay, welcome. Our next speaker is someone we all know and who's an associate professor in obstetrics and is a delight. And Dr. Dawu is going to speak on advances in OB management of preeclampsia.
We're going to start basically talking about preeclampsia. Everything we learn is it's a very developing disease because we have been changing within the time. And the last time we settled a little bit on the classification was 2013, as Dr. Toledano mentioned, in our task force in Bethesda. And we finalized that to be as chronic hypertension, preeclampsia with or without severe feature, eclampsia, preeclampsia superimposed upon chronic hypertension and gestational hypertension. And the spectrum can be added to the HELLP syndrome to include. Chronic hypertension, as we know, is blood pressure, as any adult will have 140/90 prior to pregnancy. Usually we diagnose before 20 weeks, and when it is diagnosed before 20 weeks, which is during the pregnancy, it has to continue beyond the pregnancy after 42 weeks. And that's what we call an adult disease, that primary cause of major medical issue as chronic hypertension. It has carry significant morbidity and mortality for the mother, as it complicated almost 4 to 5% of pregnancy. Mild hypertension in this cases, which is in the chronic hypertension, does not increase the morbidity or mortality, while if diastolic above 105 has carried significant increase in vascular accident. Superimposed preeclampsia occur almost in 20% of patients who have chronic hypertension. The prenatal morbidity and mortality goes to superimposed preeclampsia, which is basically increase the prenatal morbidity and mortality, and we'll see later, and decrease uteroplacenta perfusion, in addition to causing higher risk of placenta abruption and FGR. Preeclampsia, which is our main subject today, is the onset of hypertension more than 140/90 with or without proteinuria. Usually 300 milligram is the cutoff that we use, and we still, if there is no proteinuria, and this is supposed to be after 20 weeks of pregnancy, we must meet one of the criteria that can define the disease, which is thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, and cerebral and visual disturbance. and preeclampsia with severe feature, which is the high-risk disease that used to be the severe preeclampsia in the past. It's blood pressure more than 160 or more than 110. You don't have to have both components. Cerebral and visual disturbance, epigastric pain and tenderness, which is basically expanding of the liver capsule, and pulmonary edema or cyanosis, thrombocytopenia, elevated liver enzyme, and oliguria. As just because I'm mentioning pulmonary edema, the recent study, and Dr. Toledano mentioned that it's all go back to the cardiac and the use of echo during patient evaluation of the progressiveness of the disease. Recent research even related to preeclampsia as kind of myocardial function problem rather than anything else. And that's why I think the echo during evaluation of patient for progressive preeclampsia disease can carry in the future significant role. Chronic hypertension superimposed preeclampsia defined as exacerbation of the hypertension, systolic of blood pressure by 30 or diastolic by 15, or increased mean arterial pressure by 20. Proteinuria usually worsen, and this is just stayed as historical, really to show that the progressiveness of the nature of the disease rather than it's not a steady condition that diagnosed at that moment and you have to act upon it. Gestational hypertension is a unique things that we really don't know what to do. Most of this patient will be placed on magnesium and managed like they are preeclampsia, though reality, because the ability to make the diagnosis goes beyond the pregnancy, almost 12-week postpartum, which is at that time we will not see the blood pressure. So it's a blood pressure during pregnancy without proteinuria, that retrospective diagnosis after a pregnancy. Usually 12 weeks when it disappears and the blood pressure normalizes. It's called hypertension alone, gestational. And the risk factor to develop preeclampsia are many, and this is carry significant for evaluation of our patient because it has significant role to start taking care of the patient as early as possible. Nulliparis ratio is 3:1, age more than 40 is 3:1, African American 1.5:1, family history of pregnancy-induced hypertension 5:1, chronic hypertension 10:1, and chronic renal disease 20:1. The other risk factor, antiphospholipid syndrome 10:1, diabetes is 2:1, and twin gestation 4:1, angiotensin gene T235 in heterozygous status is 4:1, and homozygous is 20:1. So we go back to basic preeclampsia epidemiology. We know now that even in our institution is around 6% to 8% of pregnancy. Nulliparis carry the highest number of these cases, which is 85% of the cases. Socioeconomic status also, extreme of childbearing age, hereditary, and medical disorder like chronic hypertension, diabetes, renal disease, obesity, and collagen vascular disorder. A pregnancy-associated factor has significant role in increase the risk of preeclampsia, multiple gestation, fetal hydrob, and fetal chromosomal abnormality. Reality, most of the cases that we see, there's so many case reports before 20 weeks, which is the cutoff of preeclampsia diagnosis, usually is patient who carry this kind of what we call fetal factor. And preeclampsia etiology, as we see, we can throw everything. Abnormal trophoblastic invasion, coagulation abnormality, vascular endothelial damage, immunological phenomena, genetic disposition, diet deficiency or excess. And all this shows that we're still seeking an answer, and we are here. You will see that we're trying for years now to play a major role in two components of this list, which is the immunological phenomena and the genetic disposition. And we have some result that Dr. Zhang will be talking about. So in the uterine vascular changes that we see in the preeclampsia, normal pregnancy usually there is endothelial and spiral artery are replaced by the trophoblast. Also, internal elastic lamina and smooth muscle of the media are replaced by trophoblast and fibrin. This begin usually in the decidual portion of the spinal artery and expand beyond to the myometrium segment. That all to help the uteroplacenta bed, what we describe as a uteroplacenta bed, which is provide the fetus for all the nutrition requires, characterized by two major things, which is low resistance and high flow. In the preeclampsia patient, this, however, will be changed. We'll see lack of or incomplete of trophoblast-induced physiological change. And despite of muscular elastic architect is retained in the placenta and bed, as response to the hormonal changes and influence, there is a significant decrease in the spiral artery, almost 40% in diameter. And the spiral arterioles that can also affected by the acute atherosclerosis, which is basically a prominent lipid-rich foam cell replace the lamina. All this will play a major role in the manifestation of the disease, which is decreased uteroplacenta blood flow. If this was one of the earlier studies in the early 90s that show us how we went down in our ability to recognize preeclampsia as a syndrome related to pregnancy. Before we waited till the symptoms appear and then we get some major lab test. Now we can measure uterine artery Doppler and we see that patient who has developed preeclampsia later on in pregnancy has significant elevated with uterine artery. This was a Doppler study. This was recognized around 22, 23 weeks. So now we are in that stage. Then later on we went even further and we'll come to explain it again. As hepatic pathophysiology, we know that there is almost 70% of liver of patient who has dying for preeclampsia has significant changes. It could be 60% of gross lesion even, and around 10% microscopic abnormality. Hemorrhage as vasodilation and hepatic infarct as vasospasm. This is the two major hepatic pathophysiology we see in preeclampsia. In the renal system, which carry most of the manifestation of preeclampsia, we see the effect of the disease on multiple levels. It starts in the glomerular changes, which we have defined a long time ago, the hallmark of the preeclampsia as the capillary endotheliosis, which is endothelial cell enlarged and occulted by capillary lumina, an electron-dense material in the cytoplasm, in addition to basement membrane thickening, and this will lead to decrease in the GFR and increase in the proteinuria. In the non-glomerular changes that we see in the kidney, there is a dilatation of the proximal tubulus and tubular necrosis, enlarge of the juxtaglomerular apparatus, hyaline deposition in the renal tubulus, and decrease in the uric acid clearance and renal cortical necrosis. This is in the renal system, and there is another system in the kidney that affects preeclampsia, which is the renin-angiotensin-aldosterone. What we know in the renin-angiotensin-aldosterone in the normal pregnancy, that the concentration of this component system is increased, though the vascular response to this pressure is significantly decreased through decreased sensitivity, while in the preeclampsia, some component of the renin-angiotensin-aldosterone system are decreased, and despite that, we have marked increase in the sensitivity of the pressure, which basically in the cellular level at this time. And that gives us another idea to understand how deep we went in our understanding for preeclampsia. So it's not anymore second trimester, early second trimester or third trimester disease. It's not 22 weeks. It's 16 to 18 weeks when we do amniocentesis. And this sample was sent for prostacyclin thromboxane, and other prostaglandin component, which was able to define, if we know that prostacyclin is a potent vasodilator and it's inhibitor platelet, while thromboxane is a vasoconstriction and platelet aggregation, this could explain a lot of phases of preeclampsia. So during the normal pregnancy, there is an increase in the production of prostacyclin and prostanoid in the maternal and fetal and placenta tissue. And in the preeclampsia patient, that amniocentesis sample that was sent was able to figure out that the thromboxane 2 and prostacyclin PGI2 also, that ratio is increased, which is either by elevated the upper mode or the lower, which make it significant for preeclampsia if we know that thromboxane is vasoconstriction, that will lead to increased vasoconstriction, increased platelet aggregation, and increased uterine activity, uteroplacenta blood flow. So now we went down to know that the disease not only started at 22 weeks, it's 16 to 18 weeks. And hematological pathophysiology of preeclampsia are many, and we know that there is a reduction in the plasma volume, lead to rapid rise in the hematocrit as hemoconcentration. Diagnosis of DIC usually present in around 10%, and most of the time that in severe preeclampsia patient. Thrombocytopenia is most common hematological changes in the preeclampsia. Fibrinogen is rarely significantly reduced in the absence of placenta abruption. One most likely will be some DIC with the placenta abruption. And the thromboxane in that picture also have some role. Increase in the plasma fibrinopeptide and D-dimers, circulating thrombin, antithrombin 3 complex, and decrease in the antithrombin 3. All this manifestation you could see in the blood pathophysiology of preeclampsia. The immunological changes, which is put us much back in the preeclampsia ability, the disease is starting, which is go back to the early stage of the pregnancy. There is so much belief that in the time of the blastocyte, which is around 100 cells, trying to find its way to implantation in the uterus, that where some mismatch between the maternal tissue and the embryo, the newly formed embryo, form to produce and start to produce the disease. So fetal maternal immunological interaction is an etiology important in the development of preeclampsia. Pathological changes of the decidual vessel at the placental side are similar to the vascular changes that we see in acute immunological rejection. And also we have known that there is a predominance of preeclampsia in the first pregnancy, and there is a protective effect of previous miscarriages. There is a protective effect of a previous pregnancy, maybe also lost with varying the paternity, and we know that exposure to paternal component of fetal antigen through preconception sexual activity may offer protection. We did some of the research on the immunological component of preeclampsia, and Dr. Zhang will be able to add to that. I'm not going to touch preeclampsia, maternal mortality and morbidity. Now it's a placenta abruption, hepatic rupture, eclampsia. And prenatal morbidity and mortality is placenta insufficiency, abruption placenta, prematurity, fetal growth restriction, and it is less favorable for twins as outcome. HELLP syndrome, as you already know, hemolysis and elevated liver enzyme, low platelet. And if you look at the number, you will see AST/ALT is 72, can make the disease significantly severe. And if we know from medicine, AST/ALT could be in 1,000 with hepatitis and other disease, and will be not an issue for internists. So in preeclampsia is totally different, and we deal with the severity of the disease in different level. Complication of HELLP, much more difficult and much more severe, and it also takes longer time to recover. DIC, abruption placenta, acute renal failure, pulmonary edema, cerebral edema, retinal detachment, and subcapsular liver hematoma. And we see, it's extremely rare to see ARDS in preeclampsia, while it could be found much more common in HELLP syndrome. Pulmonary edema more common to be seen in preeclampsia. Management of preeclampsia, the management is really changed significantly. And if we start from our expected management of preeclampsia, which was in the late 70s, early 80s, Baha Sabai was able to fight and create the concept of what we call expected management of preeclampsia, waiting on patient in the extensive monitoring, very close monitoring, ICU setting, and labor and delivery, as we know. And then from that, fighting all effort to become able to give that in unit, very premature, severe prematurity fetus with severe preeclampsia, couple days or maybe 2 weeks in his 80 patient series in that time, was able to prolong a pregnancy up to 2 weeks in that case, unless there is an imminent reason for delivery. Later on himself, after all this suffering for all this women, and he talked about that till the late 90s, was able to read from that, and we are a little bit much more prone to not wait on suffering of the mother, whatever you can call it, reality. We are more able now with our ability basically to take care of smaller baby and the development of the neonatal medicine. Maybe we can prone to delivery a little bit earlier than it used to be in the 80s and 90s. The goal always is to prevent eclampsia, and this is the main goal, in addition to obtain the optimal outcome for the mother and the fetus. And that's the major balance, because the delivery is always an appropriate therapy for the mother. What we have the fetus that we have to give a major consideration to. And there is a major advice in management of preeclampsia. An attempt to treat the signs of preeclampsia is not an option because it will not end the disease. The only treatment is the delivery, and preeclampsia, it's reversible with the delivery. It could take a little longer time to reverse with the HELLP syndrome. Management of preeclampsia, so we balance all the maternal evaluation, stabilize blood pressure, seizure prophylaxis. We do some lab, we evaluate the cervix, presence of labor. In the fetal evaluation, we monitor the fetal heart, gestational age, growth, and amniotic fluid, considering, oh, thank you, Dr. You left me the IM steroid. Steroid is significantly important, in our, especially when severe preeclampsia, most of the time is usually early, premature. So antenatal steroid is a significant component of our management in addition to the magnesium as seizure prophylaxis. Still, the delivery is the goal, and we evaluate the mode of delivery through vaginal, which is always preferred to have normal vaginal delivery. And if cervix is in favor and the induction will take a longer time, and if the patient is less than 30 weeks, all our fight before vaginal birth before disappeared in 2002 when Baha Sabai came with his study that patient before 30 weeks, regardless with severe preeclampsia, C-section is the delivery mode, is not vaginal birth. So despite that, we can call the vaginal birth our mode of preferred delivery. Cesarean delivery of severe preeclampsia premature up to 30 weeks is still the option at this time. And our lovely medication is magnesium, because most seizure will occur during intrapartum and antepartum patient, and there is no absolute reliable predictor for eclampsia. So everybody has to be on something called magnesium sulfate. We love this medication. We use it for preeclampsia. We stop using it for preterm labor, and we use it now for neurodevelopment or protection, whatever. So it's going to be in our labor floor. A lot of people try to get rid of magnesium. It is, as we know, is the gold standard for prophylaxis and treatment of seizure in a preeclampsia patient. The efficacy and safety of magnesium for the father and the fetus is established in a major study from Parkland, and it worked through competing with the calcium for entry into the cell that will slow and block the neuromuscular and cardiac conducting system transmission, and will decrease smooth muscle contractility, and will do a little depression in the CNS irritability, but it has only transit effect on the blood pressure. So magnesium is used only for seizure prophylaxis, not for management of a blood pressure in preeclampsia. And it is not a treatment, it's to just protect the patient from having seizure till we decide about the delivery plan. And it is very good vasodilator in the cerebral, and it's cross the placenta, increase uterine blood flow, and almost exclusively excreted by the urine. So a half-life of magnesium is 4 hours when we have normal renal function. The anti-seizure prophylaxis level we require is 4 to 6, 4 to 7. At 5 to 10, we see some EKG changes. We usually don't react to it. We lose reflexes at 10. We lose respiratory at 15 and cardiac arrest at 25. So clinical evaluation is extremely important to follow up patient on magnesium sulfate, pulmonary edema, urine output, and repeat serum level. The antidote for magnesium has to be known as IV calcium gluconate. It's an ampoule, 10 ml of 10% solution, and it's given IV slowly. You give 2 to 4 gram IV push and followed by bolus, and we follow by 2 gram an hour on continuous infusion. If you don't have the machine, still there is place to give IM, followed by 5 gram IM Q4 hours. A preeclampsia with severe feature, which is basically have to figure out when to deliver, and there is certain criteria to give an indication for delivery. Uncontrolled severe hypertension, eclampsia, you stabilize and you deliver. A platelet count less than 100,000 or AST/ALT more than 2 times the norm, and with epigastric pain or right upper quadrant pain. It's basically liver capsule expansion. Pulmonary edema, compromised renal function, persistent severe headache or visual disturbance. And that will give you an indication for delivery of preeclampsia, a severe feature. Fetal indication for delivery, repetitive fetal heart rate deceleration. Biophysical profile is 4 in 2 separate occasions, and oligohydramnios. Still till now, FGR and increased placenta resistance, which is a Doppler study on the placenta, did not make it to the indication to do a delivery. The FGR usually managed as usual, the same way we manage FGR in other pregnancy. Doppler studies still need more time maybe to make it up to the decision to deliver placenta with a patient with preeclampsia. Antihypertension and therapy, hopefully I'm not repeating myself, but we know that is not routinely utilized in the treatment of preeclampsia. As we said, signs of preeclampsia does not treat with the antihypertension medication or other medication. We usually treatment is the delivery. Severe preeclampsia and eclampsia are associated with generalized arterial vasoconstriction that will lead to severe elevation in blood pressure. In this case, there is some antihypertension agent is used to reduce the risk of maternal cerebrovascular and cardiovascular events without compromising cerebral or uteroplacenta perfusion, which we start at the level of diastolic 110 and systolic is more than 160. And the medication that have to use very cautiously, and we don't need to decrease the blood pressure quickly and fast as usual, and we justify 20 to 25% reduction in mean arterial pressure, and we have to maintain cerebral autoregulation. Preferred medication are those who had rapid onset, short duration, and they don't do significant effect on cardiac output. Our main medication that we use and recently start getting strong ground in our labor floor after long neglect, labetalol, and a combined alpha and beta blocker, which is does not reduce after load. Start in onset with 1 to 2 minutes and peak in 10 minutes. Duration go up to 16 hours, and the dose is 20 milligram IV, and we can increase the dose every 20 minutes up to 300 milligram. The second dose medication, hydralazine, it is a direct vasodilator. It's increased cardiac output and increased uterine blood flow, but has blunt hypotensive effect. The onset start 10 to 20 minutes and it peak in 20 minutes. The duration is 3 to 8 minutes. The dose is 5 to 10 milligram IV bolus, and we repeat it every 20 minutes. The maternal side effect that we watch for is headache, palpitation, and nausea, vomiting. Nifedipine calcium channel blocker is potent vasodilator, does not reduce cardiac output. You start the onset 5 to 10 minutes and peak in 20 minutes. Duration is 4 to 8 hours, and the dosage is 10 milligram. It has some synergic effect in the receptor of the with magnesium sulfate. Can be preeclampsia prevented? We tried. Sodium restriction shows no evidence. Bed rest did not do anything. Magnesium and zinc supplement shows no evidence of prevention. Calcium supplement was major study about it, and it also basically shows no changes in the relative risk for preeclampsia of any level of calcium. And then we came to discover again aspirin. Aspirin we knew that have a major effect through the prostaglandin cycle, and since that time there was a major study about aspirin. Almost 9,000 patients, more than 9,000 patients. All that end up that aspirin increased the risk of abruption. And the study has to stop in the beginning, and we forget about aspirin till recently. Almost 2 years ago, we know that aspirin become a major role on our preeclampsia and other disease in a pregnancy. Aspirin suppressed the production of prostaglandin and thromboxane, and it's irreversible inactivation of the COX-1 and COX-2, and it is non-selectively inhibit both. So women at increased risk of preeclampsia treated with low-dose aspirin between 60 and 150 milligram between 12 and 26-week gestation reduced the risk of preeclampsia by 24%, reduced the risk of preterm labor by 14%, reduced the risk of FGR by 20%. So U.S. Prevention Service Task Force found adequate evidence that low-dose aspirin did not increase prenatal mortality in women at high risk of preeclampsia and does not increase a risk of placenta abruption, which was the reason for a previous abandoning of aspirin from our pregnant high-risk patient. And postpartum hemorrhage also did not increase, and also intracranial fetal bleeding did not increase. So recommended aspirin for everybody almost, the U.S. Task Force. Our college, however, and SMFM recommended only for this high-risk patient of pregnancy. History of a previous preeclampsia, especially when accompanied by adverse outcome, multi-fetal gestation, chronic hypertension, type 1 and type 2 diabetes, renal disease, and autoimmune disease. This patient will receive aspirin as prophylaxis starting at 12-week or as soon as they start prenatal care. We cannot start it after 26 weeks. The U.S. Task Force of Prevention, though, add the moderate risk to these people, which is nulliparity, obesity, family history of preeclampsia, mother or sister, socio demographic characterization that they have list for it, and age of 35, personal history factor like low birth weight or small for gestation age, previous adverse pregnancy outcome, or more than 10-year pregnancy. The low risk definitely is not included in that. For now, if you won't have any question, you are very welcome.
So on the criteria for the diagnosis of preeclampsia, it talks about creatinine worsening over 1.1, et cetera, and LFTs. Why on the labor and delivery floor do we hear people talk about the protein-creatinine ratio?
It's really not much.
Why isn't it in the criteria?
It is in the criteria, actually. It is one of my slides, the definition of preeclampsia. And it is protein, and it is creatinine also ratio. But it really did not carry that significant in follow-up. I don't know why, in a clinical aspect, because to reach that level of severity of the disease, usually you have so many other criteria that is much simpler. So maybe that's why it is a little bit pushed to the side. But it is part, the same thing as liver function. We don't look at, we look at AST, ALT more common than we look at LDH. And the same thing as D-dimer. Nobody look at D-dimer in general. It's still any other lift, or fibrinogen split product. We don't look at it. We look at the fibrinogen. So maybe that's the reason it was pushed, but it is certainly in the criteria.
You mentioned the use of steroids. How do they work?
They work like perfect.
Perfect.
Steroid is one of the major advantage that we use in the pregnancy. It is amazing that we have to expand it now up to 37 weeks. Before we had limitation of using antenatal steroid. Now we expanded as the recent recommendation to 37 weeks. Even in Europe is giving before elective cesarean delivery up to 38, 39 weeks. There was so many evidence more than 6 years ago came from Israel that after 35-week patient who receives steroid, babies do much better. And then we carry our study in the United States and we figure out that we can give it. There is a cumulative effect of the steroid that can benefit the respiratory system, especially for the neonate, even up to 37 weeks. And we start very early, 22 plus 6, so early to give steroids for very viable patients.
You said magnesium increases cerebral blood flow. I thought they already had increased intracranial pressure, and magnesium would worsen that.
No, because of its ability to vasodilate, and that maybe create a little bit benefit because there is no decrease in the blood pressure, but there is a little vasodilator, and the vasculature of the brain vessels is much more sensitive to that, and that's why it can be affected, and this will increase intracranial flow. The same thing happened in the uterus also, exactly, the smooth muscle of the vasculature.
You mentioned magnesium interferes with nifedipine or vice versa? Or?
Yes, nifedipine have synergic effect of magnesium. So when patient on calcium channel blocker, we have to monitor a little bit more cautiously the mag level because it can have, with lower doses, a lower level could have more effect.
Any other questions? Do we have refreshments?
Yes, there's a question here.
Oh, there's a question, okay.
Are there any lifestyle factors that can reduce the rate of preeclampsia, like, for example, prenatal yoga or anything like this?
You know, all this supplement shows no, but definitely lifestyle changes that can affect preeclampsia is weight loss before the pregnancy. Getting our high-risk patient to pre-pregnancy be ready for their future pregnancy, and one of the major things that we can play a role is the weight, because obesity we know that have a significant impact on the pregnancy. And other than that, all predisposed factor as a risk factor for preeclampsia, management of blood pressure, management of diabetes before pregnancy. During pregnancy, however, we did not see all the study that we were mentioning, all these significant stories about magnesium or calcium or bed rest shows no effect on the progression of the disease. The disease is, as I stop short of talking about, which is I talk all to 5 days of pregnancy, as the applies. That we know now, there is a preposition factor, which is basically the genetic component. There's mother who carries certain genes that will have increased risk of developing preeclampsia. So, but we can maneuver with other risk factors that maybe play some role to decrease the risk and the severity of the disease.
Another special treat as a speaker, Dr. Ming Zhang. He heads one of our labs in anesthesiology. He has appointments in other departments. And he received his MD degree in China and his PhD at Rutgers and then did a postdoc at Harvard. And he's studying preeclampsia and genetic factors involved in preeclampsia. So, and he helped put this Preeclampsia Center together. And he's gotten OB and anesthesia together, and hopefully it'll be the beginning of a long relationship. Right, Ming? Okay, you're on.
Well, today I'm going to talk about the genetic risk factor in the pathogenesis of preeclampsia. As earlier we have heard from Dr. Toledano and Dr. Danu that there are two important demographic characteristics of preeclampsia. One is the pregnant African women have highest risk of preeclampsia among all racial groups. And in New York City, actually, African American pregnant women have the highest rate of preeclampsia in the New York State. So looking at the pathogenesis, actually there are many factors, multifactorial. The exact reason is still not completely clear yet. But there are many factors has been identified. Particular immune system, as mentioned earlier by our speakers, getting involved. When my laboratory here, studied the immune factors, particularly one amount of it, it's innate immune factor called in the system called complement. So throughout the years, we collaborate with our colleagues, in OB-Anesthesia, in here Downstate and other hospitals. We undergo some pilot study. I'm going to show you some of the earlier result, exciting result, and some unpublished result about genetic risk factor we recently identified. So I don't go to detail now, about this picture, but earlier speaker has talked in depth about it. I'm going to talk, give a little introduction about the innate immune system. Immune system has two branches. One is adaptive immunity. The other one is innate immunity, which is born, from the birth. So one of the earliest innate immunity system get involved is a complement. Some of you, medical students probably still remember the lectures in complement. There are so many factors. This is complicated pictures. But many start with the three major pathways: the classic pathway, lectin pathway, and alternative pathway. All three pathways will merge to a common pathway here initiated by a factor called C3, followed by other factor C5 and 6, 7, and 8 to 9. And all this, what does it do? This immune system, it see pathogens typically. When there's a pathogen comes in, they attack, recognize it, binding to that. And through a whole cascade, end up with the so-called membrane attack complex. This complex actually breaking down things, breaking down cells, whatever target it is. So once it's initiated by one of the three pathways, it ends up to kill things. So it's like an executor. So normally it doesn't go wrong. It's protective. It's a policeman. So they were on the street to patrol. But from time to time, they also cause problem, because some, like in situation like pregnancy, which the placenta, as a mother seed placenta, more like a foreign body. So it's implanted into uterus. Most of the time it goes well. There's no reaction. But from time to time, there are reactions, and we see, from earlier lectures, the severe symptoms develop. The symptoms develop because, immune system sees the fetus, the mother immune system sees fetus as a foreign, so they start to mount immune attack. My laboratory in the past few years, we we took task to get whether we can answer the question which particular immune factor may get involved. If it is involved, maybe we could use it as a risk factor to have early detection, diagnosis, or as a way to prevent. And Dr. Danu mentioned, the goal is to prevent the disease progress. So when clinicians see the patient comes in, with early sign, we already have tools in our hand to diagnose, to prevent. So what we did is, there are a number of literature earlier to show the common pathway, which is here. The common pathway here down here, particularly C3 and C5, has been involved in preeclampsia. In basic science and clinical study, has shown the activate C3 fragment, namely C3A, C3D, have been detected in the circulation of preeclamptic patient. And circulating C3A is in the first trimester of pregnancy is an independent predictive factor for preeclampsia, and local C3 deposition in placentas of preeclamptic patient is significantly elevated. And moreover, in the animal model, the treatment of C3 inhibitor has able to decrease the level of indicator of preeclampsia in the rodent animal model. About C5, which is downstream factor, the increase of C5A, which is a breaking down component, it's found in the circulation and the urine of preeclamptic patient. And local deposition of a C5 to C9, which is a terminal complex, is found in the placenta from preeclamptic patient as well. And this directly leads to the nominal necrosis of placenta membrane. And more recently, there's a study, a case study by Harvard group. They use the anti-C5 treatment to one patient case study with severe preeclampsia. They were able to extend the pregnancy for 17 days, which is very significant, with no apparent consequence. So this indicates the complement pathway, the common pathway, it is involved in the development of preeclampsia. So what we were trying to do is we were asking, well, if common pathway involved, what about the upstream pathway, right? So there are three pathways I mentioned earlier. So we undertook the pilot study. We enrolled more than 200 patients with a prospective study, with 190 normal patients. Most of here, as I mentioned, here we serve African American patients most in this community. We enrolled 34 preeclamptic patients. And compared to the this group, which normal pregnancy, compared to the preeclamptic patient, the factor in the alternative pathway of complement is the early factor called factor B, is significantly activated in the African American pregnant women with preeclampsia. And there are some other study, parallel study showing. There's one study in Colorado showing with a mixed racial population, they have 20% of African American population. They show there's also increase of this factor B as well, but their level is not that high because they have a heterogeneous population. We have a more homogeneous population here with African American patient. So, which is quite interesting. We published this in 2015. Our colleagues are all accredited in the authorship. So now we have identified this earlier factor B is in the alternative pathway, abnormally activated, and we have shown you the other people have studied in the common pathway also found C3A, C5 has been involved. So it looks like the pathway is getting clear from protein end, so pathogenesis-wise. So now the question is, what drives this factor B abnormally activated? So what's disposable factors contribute to the abnormal activation of the factor B in this pathway? So again, we look at the literature. There is one report by a group in Cornell. They look at the patient, preeclamptic patient, about 50 patients. They look at those patients and look at whether there are genetic contribution, in the regulation of this complement cascade. As shown here, the factor B here is regulated by a number of factors, such as factor H, MCP, and the factor I. So in this I would call it pilot study, they actually found among the patient, the patient they recruited 40 patients, and 18% of them, which is 7, they have a heterozygous mutation of the complement regulatory genes. 4 patients with a mutation in the MCP, 2 with CF5 complement factor I, and 1 with complement factor H. So that they show that the mutation, it's not high, right? One of the reasons we look at their paper, we found their patient population is also heterogeneous. It's a mixed racial population. So again, we take advantage because we are serving the community which is predominant here, African American. So we recruit a patient, paired patient, compare preeclamptic patient and a normal control. So we have 50 patients of preeclampsia, but all of them are African American, 25 normal control. With this study funded by pilot study by Downstate President Award for Health Disparity Pilot Project Fund. and also get a fund from New York State Department of Health, the EQUIP Award. So we were able to collaborate with our colleagues in Lutheran and Kings County. We recruit those patients. There's a demographic, so a matched patient with a control. And we take advantage of the new technology called next generation gene sequencing, which there's a very good commercial vendor called GeneWays in New Jersey. They help us do this genomic project. So what it does is they cut down the genomic DNA, break it into pieces, add a linker, and put the linker into the library on the like a matrix, the chips, and did in situ PCR, and followed by sequencing and imaging by they have a special machine to image that. And this process goes through 100 times to one end, the other 100 times from the other end. So it's both 5' end to 3' end. So both 100 times, in depth, to minimize error. So this is our pilot result, which is very exciting. So it's like very complicated, but essentially, we have identified, with this new technology, a number of mutations. Actually, these are about 50 potential mutations in complement regulatory protein in their genes. At 14 of them, the mutations are very unique to the patient and not found in the normal control. So this is very exciting. So we have here to show that the complement factor B, the factor which is at protein level, is abnormally activated in African pregnant women with preeclampsia. And genomic mutations are detected in the regulators of complement factor B among the preeclampsia patient. What's so significant? The significance is if we can validate the project where we want to expand it to go through probably 500 patients each arm, 500 patient versus 500 control. Want to validate the result. If the success of this project, we probably identify the genetic origins of preeclampsia, the contribution. Maybe we can help to early diagnosis, to identify the patient with early on with a risk, and maybe provide a way for the treatment as well. So. That here, I want to thank my colleagues, our chairs, Dr. Joel, and Dr. Vilakovic, and Joanna, also very helpful, and my lab members, and our colleagues in OB, and in Lutheran and Kings County. And thank you, and also thanks for the funding from our president and our New York State Department of Health. Yeah, do you have any questions?
I want to ask if you corrected these genetic findings, if you corrected for all the factors within the group, and you may have had a small sample. So was that corrected towards the other criteria, morbidities of these patients?
Well, we are going to do larger study to validate that. And obviously, like you say, we probably need to the covariance to consider all those other covariants. The good thing is we're doing the paired sample, so the patient sample that we match their age.
You found a trend.
We found a trend, right?
Now you want to substantiate.
Right, larger study. So so that's what we want to do next. Yeah. Okay. Yeah.
Other questions? Have you found this factor in other ethnic groups?
Well, the factor B is found. The factor B is found in everybody has factor B, but it's a matter of abnormal activation. So we found that in a patient with preeclampsia, this factor is significantly activated. So we all carry this immune factor around, but they don't go around normally. But as pregnancy, there's the immune reaction we see from fetus to the mother-fetus interaction that cause abnormal activation of this factor. So.
Okay, anything else? All right, thank you. So our next speaker is from the Board of Directors of the Preeclampsia Foundation, and I think they're bringing knowledge to the field in preeclampsia, trying to find causes and raise money to treat it and prevent it as well. And she's going to tell us a little bit about what the foundation does. And her name is Allison Galbin Gurnett, right? Okay, thank you very much.
Good morning. I'm really excited to be here representing the Preeclampsia Foundation. We are a nonprofit organization whose goal is to inform the public, educate patients and providers, and to help support research for preeclampsia. I joined the board of the Preeclampsia Foundation last fall. I am the only member of the board who is not a personal survivor. And so I brought a different perspective to being a board member for preeclampsia. I'm responsible for designing benefit programs for a global organization. So I'm a healthcare payer. I pay for the costs of healthcare for approximately 25,000 people in the United States. And in that role, my company globally has 130,000 employees. 70% of them are female. The average age is 33. We have a lot of babies, lots and lots and lots of babies. And we're a very female-friendly organization in terms of providing benefits to our employees. So we provide infertility support, we provide adoption support, we provide pretty much anything we can do to help our employees with their pregnancy. And lo and behold, I was learning in my role that way too many of our employees were suffering from preeclampsia. I personally had an employee, a member of my team, who had preeclampsia. I did not know she had preeclampsia. Her baby did not survive. We've had other babies who are $1 million babies, $2 million babies. Some survive, some don't survive. And I concluded that that's just not the way the world is supposed to work. Women and babies are supposed to live. They're not supposed to die from something as simple as what we think of as pregnancy. So I got involved with the Preeclampsia Foundation. Our ultimate mission is to eradicate preeclampsia. Now, it's a pretty bold statement to say that we want to put our foundation out of business, but that's pretty much what we want to do. We know it's not going to happen in 2 years or 5 years or 10 years, but the research that we're doing and that we're trying to support is for that primary purpose. We don't think that women and babies should be dying from preeclampsia. So our emphasis is on patient education, provider education, and research. We have a registry of women who have had preeclampsia, who have family members with preeclampsia, and we provide our data free to researchers. So a lot of postdocs access our data and use that to try and identify ways to help prevent preeclampsia. We were an integral part of the studies where it was determined that aspirin was a viable approach to treating preeclampsia. Our patient base was critical in that study. So that's pretty much what the Preeclampsia Foundation does. We're a $1 million organization, which is a really, really small charity. Half of our money is raised grassroots through local walks and fundraisers that our members conduct in their local communities. The importance of me really being here, though, is to tell you that preeclampsia is a disease that affects people. And to that end, I want to introduce Jennifer Siegel-Gashevsky, who is a preeclampsia survivor, to share with you her story, what she went through with preeclampsia.
Hi, so as Allison said, I'm here to share with you my experience with preeclampsia from the patient's perspective. So thank you for having me. Thank you for planning this symposium and the work that you all do. It's very important. Can you hear me? Okay. Until a year and a half ago, I didn't even know what preeclampsia was, but since then, it has had a very big impact on my life. I was 33 weeks pregnant and had just had my baby shower. Up until that point, I'd had a very easy pregnancy, but I started to feel nauseous and generally not myself. I attributed this to too much cake at the shower and traveling for work the week before. I also thought it was just the general discomfort of being 8 months pregnant. After 2 days of discomfort, my husband came home late from work one day and said, "You look awful," which is something he would never say to me. I said, "I feel awful." At this point, I decided to call my doctor. After talking to the on-call doctor, I went to labor and delivery to be checked out. Fetal monitoring showed that my baby was fine, but my blood pressure spiked once during my time there. My doctor, being very conservative, ordered a 24-hour urine test. I was sent home in the middle of the night with instructions to monitor my blood pressure and repeat all the tests when the 24-hour test was complete. Following day, I dropped off my sample, had blood drawn, and fetal monitoring repeated. During the fetal monitoring, I noticed that I sat there and watched my feet swell and my hands to the point that I had to take off my watch because they just didn't fit anymore. My baby looked fine, so I was sent home. But at this point, I started to feel scared. After a sleepless night, I decided to call my doctor. Just as I was getting ready to call her, the phone rang. She had gotten my results from the 24-hour test and told me I needed to get to the hospital immediately. She wanted to admit me for observation. She said that in her experience, the vague, nondescript, "I just don't feel like myself" with my blood results were trouble. It was during this phone call that I first heard the word preeclampsia. I had never heard that before. I had a vague recollection that this had something to do with high blood pressure, which really surprised me because my blood pressure had been normal during all of my prenatal visits. We talked about what would happen next. I would be admitted to the hospital and closely monitored. My doctor said she would like to get me to stay till at least 38 weeks, but that I should be prepared for the possibility that my baby could be delivered that day. I asked her if I could wait till my husband got home so he could come into the hospital with me, and she said, "No, you need to get here immediately. This is serious." I really don't remember much about the rest of the conversation because my head was spinning. I looked around at the crib that was not yet assembled and the baby shower gifts that were not unpacked. I called my husband John and left him an incoherent message to meet me at the hospital, and then I faced a really unique challenge. How would I get from Brooklyn to the Upper East Side on a day when President Obama, the Pope, and the UN General Council were in town? Luckily, I was early enough in the day and the streets were empty, and I got to the hospital in record time, and my husband followed shortly thereafter. So there I was, back in the same room I had been in 2 nights ago, hooked up to the same fetal monitor, having blood pressure taken and blood drawn. My doctor came in to see me right after my first lab work came back. She said my preeclampsia was sudden, severe, and atypical. My kidneys were shutting down, and the best option was to deliver immediately through a C-section. She assured me that my baby was not in distress, but if we waited any longer, we would both be at risk for bad outcomes. While not ideal to deliver at 34 weeks, when weighing the options, I was far along that this seemed like the best choice. I remember being told that there is no cure for preeclampsia and delivery is the best option. There was no time for second guessing, and we all agreed that this was the way to go. There was talk about risks and what to expect, and then I was taken to the operating room. I distinctly remember my son, who we named Toby, being handed to me in the operating room, and noticing how small he was, particularly his hands and his pinky. I'd never seen anyone so small before. As I was taking in this beautiful boy that I was so excited to meet, I barely got to kiss him before he was taken away to the NICU for evaluation. My husband followed behind him and looked at me, and I could see that he didn't know who needed his attention more. The room was freezing cold, and I was shaking with fear, and I said, "Go and make sure he's okay." I felt even more devastated upon hearing that I was being given magnesium sulfate, and I would not be able to go to the NICU with my baby. All I wanted to do was be with him and make sure that he was okay. Over the next 2 days, I kept begging the doctors and nurses to go see him, and they kept telling me, "You need to get better first before you can take care of him." There are no words to describe the emptiness of having a baby, not being able to hold him, and not being able to be with him. I'm his mom, and he needed me. It wasn't just hard on me, it was hard on my husband, who looked like he was split in two. He spent his days running back and forth between the NICU and the maternity ward with me. Late one night, when he was in the NICU giving Toby a bottle, I had a pounding headache, and I buzzed the nurse for Tylenol. My blood pressure was taken, and while I don't remember the numbers, it was high enough that a resident came in and gave me an extra dose of blood pressure medication. A nurse came back to check on my blood pressure a while later, and the next thing I knew, my room was filled with about 6 doctors. What stood out is someone introduced himself as an attending, and that scared me, since the late night care had always been with residents. One of the doctors sat down on my bed and explained that they were trying to decide what to do. They were considering transferring me to the cardiac unit because they were afraid I was going to have a heart attack or a stroke. All I kept wondering, though, was when will the magnesium stop and when can I go see my baby? My husband came in the middle of this with a look of terror on his face. Luckily, I did not have a heart attack or a stroke, and after a few days, I was stable enough to go to the NICU and spend some time with Toby. I'm still haunted by the sounds of beeping alarms I heard as I walked towards his incubator. When I saw him, his tiny baby with IVs and wires, I felt so terribly sad that this was his entry into the world. I picked him up and held him to me, and he let out an instant sigh of relief. Here are some pictures from that day. There are many pictures of Toby from this time in the NICU, and these days, with Facebook and social media and cameras and smartphones, everyone wants to see pictures minutes after delivery. Once everyone got over the news that Toby was born just days after his shower and weeks before he was due, everyone wanted to see pictures, but I just couldn't do it. I couldn't share pictures of this tiny little baby with wires. In the end, Toby spent about 3 weeks in the NICU, and at one point after his oxygen came off and his mask came off, I took a photo of him, in which I thought he looked like a little baby Buddha, and I was finally able to share his picture. It took about 7 days for my vital signs to return to normal so that I could be released from the hospital in the care of a hypertension specialist. In my post-follow-up delivery, my doctor said, no matter how many times she's dealt with preeclampsia, it's always very scary. In addition to the physical symptoms, I also want to emphasize the emotional impact of having preeclampsia and that this should not be minimized. It has an impact on both parents and whole families. People will still say to me, but it's okay. Everything worked out. In the end, your baby is fine. And while that's true, it's very important to acknowledge that this is a very scary experience. In the past year, at the Preeclampsia Walk and at other events, I have heard from many other mothers who had preeclampsia and a baby in the NICU say that they feel that they have PTSD from this experience. A common theme is that everyone expects childbirth to be an uncomplicated and joyous event. You go into labor, you deliver a healthy baby, you get to bond with them. But because of the situation surrounding Toby's birth and my severe and sudden onset of preeclampsia, this was a terrifying time. We were filled with fear about Toby's health and about my own health. Several months later, I did a Preeclampsia Foundation Promise Walk and was able to talk to other families who had similar experience, and there was some comfort in that. I consider myself incredibly lucky. I had a great doctor who acted quickly, and both my son and I recovered. As you can see, you could never tell that he was a preemie. And yet I look back at this time and I wonder, how did this happen? Despite receiving excellent care, preeclampsia was never mentioned. When I began experiencing symptoms, I thought it was just the normal par for the course of pregnancy. If not for my overly insistent husband, I don't know whether I would have called the doctor, and I might have waited several days or weeks or waited till my next appointment. I am sure that there are other women out there that are like me. I'm sure that there's other women out there who don't know what preeclampsia is, who don't know what the signs are, who don't know what to look for, and who are afraid to speak up. So this is why I think that the Preeclampsia Foundation and your center are so important. Educating women, educating doctors is so important, especially if it can save lives. So I would like to thank all of you for letting me share my story. While it's not always easy to talk about, I feel it's very important. Thank you.
Well, I think that really sums up what we're all about, and everything we've been discussing and talking about has been directed towards the patient and having better outcomes of the baby as well as the mother. So unless there's someone else who wants to say something, I think our conference is concluded. So I want to thank all the speakers for giving those wonderful speeches, and thank you as a patient for coming, and from the foundation as well, and from the Caribbean Women's Association. Thank you.